A very good afternoon to one and all. I am Arpita from the IGCP group. Welcomes you all to yet another webinar with us on the topic weight regain after stoppage of GLP1 RAS myth versus reality. And to address the topic, we have Rastogi sir. It's an honor for me to welcome sir to our platform and to introduce him to MD, then DM. He has done MNA, MS, FACE, FRC of endocrinology and metabolism at the PGI-MER Chandigarh. So with this very request him to please start with the topic for today. Over to you, sir. Yes, sir, please go ahead.
So good afternoon, everybody. So today we'll be discussing a very important topic, that is obesity, the weight gain and the treatment of that, and then weight regain after stopping GLP1RAs. We know that obesity is now a pandemic, and in our country there is a huge problem now. So this can be coexisting with diabetes, then it causes diabetes. But overall prevalence of obesity is also huge, and there has been recent studies that has been published in Lancet from our own country, that was an ICMR data, and it shows that almost 40% of our population is obese. And that obesity is defined by the current Southeast Asian cutoffs of a BMI of 25 rather than a BMI of 30, as it is done in Western counterparts. That is very relevant BMI cutoffs of 25. And with that, almost 40% of our population is obese. That means it is a huge problem. And even from the various cities, you'll be surprised that the highest prevalence of obesity is from the Union Territories. And that Union Territory is Puducherry, which is the highest prevalence of obesity, which is followed by certain other cities. And the city from where I come, like Chandigarh, it has almost 44% of the women that are obese, and almost 37% of the men are obese. So that means that is a huge problem. So this problem definitely we like to tackle with a certain kind of intervention, and the best intervention that can be done in these individuals would be a lifestyle intervention. The problem with lifestyle is that they recommend that you should have at least 5% of weight loss. That is possible by restricting calorie intake and having a good exercise schedule, which includes at least 150 minutes per week of exercise, at least 30 minutes per day, and no 2 days without exercise continuously should be there. I don't know how many of the people would be able to continue with that lifestyle. And even you can see this beautiful study, which was published in Medical Clinics of North America. They showed that once the patient was on intensive lifestyle treatment, there was significant reduction in the weight. So you can see with all kind of interventions, there was significant reduction in the weight. But problem is, as soon as the intervention is stopped, there is again increase in weight, and it is irrespective of different kind of studies that has been done till date. So you can see way back in 1984, there was a study by Stellanos, then there was studies by Vogels, Werden, and recent studies also by the Schwarzfuchs that have showed that most of the individuals regain whatever they have lost during the intervention period with lifestyle intervention. So it is said that the weight loss within the first 2 years, almost 80% of the weight is regained in the next 5 years. So lifestyle intervention can lead to weight loss, but one, this is modest, only 3 to 5%. And more importantly, once you stop lifestyle intervention, there is weight regain. Definitely you have to look for certain other kind of interventions, and that interventions can be in form of pharmacotherapy. But the question remains, why it is difficult to maintain that weight loss in long term once established obesity is there. So there is inherent resistance in our body to maintain a body homeostasis. So a person who is obese, his body is accustomed to that homeostasis of weight. Therefore, once the patient start losing weight, there is certain adaptations go on both at the peripheral level as well as the central level. And this is related to the change in the satiety hormones, predominantly the GLP-1 and the leptin and the pancreatic polypeptide. These are satiety hormones, but these hormones decrease when these patients eat more. And there is increase in the hunger hormones. And overall, there is decrease in energy expenditure also with weight loss. And both of these, the change in the hormone level as well as the change in the metabolism, lead to again weight regain. So it is very important that chronic weight management requires intervention that can address both these hormone levels as well as the change in the metabolism. And remember that in our body, the diet or the appetite or the satiety is regulated by first the need, because when we consume energy in terms of doing activities, definitely we'll feel hunger. But there is hedonic eating also, and hedonic eating means when the patient is doesn't require calories, but just because of the pleasure, he or she starts eating. So we need certain interventions that can curb the hedonic eating as well. So overall, this weight regain or weight gain is a story of the balance between the energy intake and the energy expenditure. And all of this is regulated through the brain, but which is receiving the signals from the peripheral centers like adipose tissue, which secrete leptin, the pancreas, which secrete the pancreatic polypeptide, the cholecystokinin and other hormones, the gut, which secretes GLP-1, and it also determined by the genetics and the medications. So in a patient who is having an active lifestyle, who consume a lot of calorie foods, and a lot of psychosocial factors are responsible, which overall leads to more of energy intake rather than energy expenditure. And as I mentioned, that hedonic inputs are very important when the patient has more pleasure in eating because of palatability, which also leads to more energy intake and weight gain. So these are three main kinds of eating, as I was mentioning. One is homeostatic eating, second is hedonic eating, and these two kinds of eating function then correlate with executive function and when the patient decides to eat. So homeostatic eating is eating for hunger. So it is controlled mainly by the endocrine feedback signals, and eating for pleasure is controlled by the brain's reward system. So patient just feel a reward in eating. So appetite is regulated by this complex interplay between these different signals, which are responsible at the level mainly of the nucleus tractus solitarius and area prostrema of the hypothalamus, which are the predominant regulators of eating. So you can see this direct activation of the hindbrain, mainly in the area prostrema and nucleus tractus solitarius. And there is the hypothalamic centers, which are responsible for regulating the appetite and the cravings. But we have drugs like GLP-1 analogs like semaglutide, which can directly cross the BBB or blood-brain barrier and have direct access to the lateral septum, which can reduce the energy intake and they can reduce the weight. So overall, GLP-1RAs are known to cause significant amount of weight loss, no doubt about that. So just a few slides about those, that what is the efficacy of GLP-1RAs in reducing weight loss. So this is a step 1 study, which is done with semaglutide 2.4 milligram, which was used subcut. And you can see the mean body weight at baseline was 105 kgs in the individuals. They were randomized into placebo, which is depicted as a green line, and patient with semaglutide is depicted as a blue line. So these patients were followed over these 64 to 68 weeks of follow-up, and you can see a dramatic decrease in the body weight. And overall, there was around 15 to 16% body weight loss around 1 year or 48 to 64 weeks in patients who were randomized to semaglutide, as compared to only 2.4% weight loss with placebo. So there is absolute difference of around 14% in the weight loss with semaglutide when it is placebo corrected. More importantly, almost 1/3 of the patients who were also offered semaglutide had more than 20% weight loss. So that is a very important effect, and that has been further seen in step trials, whether it is step 3, step 4, step 5, and all of these showed a consistent weight loss of more than 15% in these individuals. And remember that diet and exercise lead to around 3 to 5% weight loss. But this is a drug which can lead to significant weight loss of 15%. Same is with the dual agonist like tirzepatide, and this is SURMOUNT-1 extension phase trial. So what they did, they give tirzepatide in 5 milligram once a week subcute, or tirzepatide 10 milligram once a week subcute, or tirzepatide 15 milligram subcute. These patients were initially screened and then doses were titrated and escalated to reach the optimum tolerable doses, and that was maintained for a period of 72 weeks. So in this trial, they did not have patients who had diabetes. They had patients who had a BMI more than 30, who had more than one unsuccessful attempt to reduce weight just by diet. And then in the SURMOUNT-1 extension phase, they also wanted to study the glycemic effects of the tirzepatide by having patients with pre-diabetes. The primary objective was to demonstrate the superiority of tirzepatide as compared to placebo over a week 72. And they also wanted to study the risk of progression of pre-diabetes to diabetes in these patients who were overweight and obesity over a period of 72 weeks. So this is how this trial was designed, and a very pragmatic design of trial. Primary completion till 72 and then followed over a period of 176 weeks. So you can see with increasing doses of tirzepatide, there was significant reduction in weight. With 5 milligram, 15, with 10 of 19.5, and further increase in dose lead to even 20% weight loss as compared to only 3% weight loss in with tirzepatide. So tirzepatide overall can lead to weight loss of around 20 to 21% at the end of week 72. And remember that this amount of weight loss is really phenomenal. It's very difficult to achieve with lifestyle, and this amount of weight loss can have significant metabolic benefits, whether in terms of dysglycemia, hypertension, dyslipidemia, and even fatty liver, or NAFLD or MASLD as we call it. So they followed these patients, and over a period of 176 weeks, this weight loss was maintained. So initially there was 20.9% weight loss over 72, but when these patients were followed, at the end of 176 weeks, it was 19.7% weight loss with tirzepatide. But problem is, the most important question is, we are giving tirzepatide, we are giving semaglutide, patient is losing weight, we are happy. But what happens is this weight loss is sustained over a long term. If you further continue this GLP-1 analogs, maybe for next 1 year, will this weight loss be maintained or weight starts to gain on the therapy? So this is studied in another trial, that is step 5 trial, where they wanted to just continue the patients who were offered semaglutide, and they found out that those patients who were having a 14.9% body weight change in 2.4 milligram arm of semaglutide, at the end of 104 weeks, they had 15.2% weight loss in step 5 trial. And this confirmatory secondary endpoint, you can see 50% achieve 15% weight loss over a period of 68 weeks, and on further continuing this drug over a period of 104 weeks, 52% patients still were having 15% weight loss, and that is significant advantage. So overall, patient who receives semaglutide 2.4 milligram over 104 weeks have a weight loss of 15.2%, and that is at par with step 1, suggesting if you continue to, or if you want to reap the benefits of semaglutide, you can continue this drug. It continues to have significant weight losing effect. So this weight loss over a period of 2 years is sustained, suggesting the durability of GLP1RAs. They do not develop any kind of tachyphylaxis for weight loss, and it can be continued for long term. And many of the patients sometimes ask us, doctor, we are taking an injection and we want to get rid of it. I have lost significant amount of weight. I'm happy. Initially I was 100. Now I'm 80 kgs. I want to stop the drug. And they say, if I stop the drug, will I have a weight regain? So let's see the data related to it. So we have seen, and when we reviewed a lot of studies related to it, whether it was a SURMOUNT-4 randomized controlled trial, or the step 1 trial extension, or this is a review that was published in Journal of Obesity, all of these say that if you stop GLP-1RA, there will be a weight regain. But important is how much weight regain. So this is a summary of the weight regain studies. You can see with semaglutide, when it was given for 68 weeks, there was 17% weight loss. But once they stopped semaglutide, there was 11% weight regain again. Same with liraglutide. Initially 68 weeks, 6% weight loss, but once there was a withdrawal, there was a weight gain again 2%. With semaglutide, there was 7.9% weight loss, and when it was switched to placebo, all of this weight loss again regained to 6.9%. That suggests that irrespective of the type of GLP1RAs, there will be significant weight regain after stopping of the liraglutide. So this is the evidence that come up from the step 1 extension study. So this is a beautiful diagram you can see. So initially for 68 weeks, the green is placebo. So they had 3% weight loss, and once the even lifestyle intervention was stopped, they had almost same weight or slight weight regain. But patient with semaglutide who had around 15% or 16% weight loss, once it was stopped, you can see dramatic increase in the weight. But importantly, though they gain around again 10 to 12% weight, but still the weight is around 5% less as compared to the baseline, suggesting that you may have weight regain, you may have around 2/3 of the weight that is lost will be regained once you stop semaglutide, but still 1/3 of the weight will be loss will be continued. So this is a very interesting. And let's see that what happens to the metabolic outcomes in this thing. So this is the change in the body weight. The change in the body weight, initially there was 17.3% weight loss, and at the end of step 1 extension, only 5% weight loss was present from the baseline. As compared to placebo, their weight was almost same as compared to the baseline, suggesting still the semaglutide has 5.6% more weight loss in spite of stopping semaglutide for over a period of next 1 year. The withdrawal led to regain of most of the weight loss that was achieved during first 68 weeks. Now let's see what happens to cardiometabolic parameters. So everybody knows once you give semaglutide, there is good amount of change in systolic blood pressure. You have 7 mmHg decrease in the blood pressure. You have 3 mmHg decrease in the diastolic blood pressure. You have also decrease in dysglycemia, decrease in blood glucose and A1C to 0.5%. Even the CRP also reduced by 57%. Now after this, you stop semaglutide. So when you stop semaglutide, there is increase in the blood pressure. There is increase in the diastolic blood pressure. There is only 0.1% decrease in the HbA1c, and the CRP also slightly increased, but still it is 38% less as compared to baseline, suggesting that the initial benefits of semaglutide, there is only a very small amount of, I would say, metabolic memory, and they then lose this metabolic memory, and again these cardiometabolic parameters also again falter after withdrawal of semaglutide. So this is the change from baseline in glycemic status, and that was seen in step 1 extension. Interesting. So initially the patients who were on semaglutide and they were normoglycemic, still some of these patients after stopping semaglutide, around 10% of patients became pre-diabetic. And same in those patients who were pre-diabetes at baseline, you can see this 94% were pre-diabetic. Once you stop semaglutide, many of these patients then progressed from normoglycemia to pre-diabetes. So 94% were normoglycemic, but at the end only 43 were normoglycemic, suggesting there is 50% transition from normoglycemic to pre-diabetes once you stop semaglutide. This is very interesting thing. Now, same is highlighted in SURMOUNT 4 trial, that is tirzepatide for weight loss maintenance. So what they did initially, their 36-week tirzepatide once a week was given, and then they divided the patient into 2 arms just to see what happens once they stopped tirzepatide. In one arm, they stopped tirzepatide and gave placebo, and another arm they continued with tirzepatide, and they wanted to understand the weight again. So as with the semaglutide, you can see there is significant reduction in the weight with tirzepatide as compared to baseline, but once you stop it, again they have weight regain. So this weight, if you continue tirzepatide, the weight continue to decrease, but if you stop, there is 10% weight regain with it. So this is an important outcome. So question is why there is weight regain, and this is responsible for mainly related to the CNS neurotransmitters, and there is inability of the CNS cells to regulate the weight gain when there is no GLP-1RA. Once the GLP-1RAs are there, both the neural GLP-1RA as well as the peripheral GLP-1RA, they regulate the weight gain. But once it is stopped, the CNS cells stop their regulation and weight started to increase, and it is also related to hormonal adaptations. So there is hormonal imbalance after again withdrawal of GLP-1RAs. There is again increase in the ghrelin, which is responsible for increase in appetite. There is dysregulation of the pathways in the CNS, and there is reduced ability to produce the GLP-1RAs, and dysfunction of the beta cells also occur, and gut microbiota alteration also occur after we stop GLP-1RA. And this is a very nice study by Sumitran, which is published in New England Journal. What they showed that once you stop GLP-1RA, even hunger also increases. So 50 individuals who were obese, overweight, who were on a 10-week very low energy diet, they lost significant amount of weight. You can see around 10% weight loss was, even 12% weight loss was seen with even low calorie diet. And they also measured appetite by measuring the VAS scores. And once they stopped this intensive low calorie diet, there was increase in the weight. And this increase in the weight was related mainly to increase in hunger. You can see initially they were on low calorie diet, so hunger was less. Once they stopped low calorie diet, the hunger start increasing. And this is the desire to eat. So their desire to eat also increases. This is again a very recent study which is published in obesity, which shows that in addition to increase in hunger, or there is this desire to eat, these patients also have now decrease in resting metabolic rate. And we know that the energy expenditure is both voluntary and involuntary. Voluntary is by doing activities, involuntary is by thermic effect of food and resting energy expenditure. So once you stop semaglutide, their resting metabolic rate is reduced by 610 kilocalories. And when you further continue, even 704 kilocalories per day resting metabolic rate is reduced. So once the metabolic rate is reduced and this much amount of calories is then added to it. And this is known as a metabolic adaptation to the weight loss. The body tries to bring you back to the same metabolism as it was initially before weight loss drugs were started. So overall, there was 499 kilocalorie per day metabolic adaptation, which was seen, and that was responsible for a weight regain in most of the patients. So overall, I would say that most of the adults with obesity or overweight may have a significant reduction in weight with GLP-1RAs, no doubt about that, especially the semaglutide, tirzepatide. But problem lies in the maintenance of the therapy. A lot of challenges. One is adverse event. Second is the cost. The third is the patient want to stop injectables. Therefore, they wish to withdraw GLP-1RA. And once you withdraw GLP-1RA, they will regain almost 2/3 of the lost weight during this treatment period. And they will also have some deterioration in the cardiometabolic variables, which will again change back to the baseline from where they started. So it reinforces that we have to stress upon the patient that you have to continue the same lifestyle modification. If you wish, it's better that these drugs can be continued for quite long, even after you achieve the desired amount of weight loss. But continuation of this will also have more of cardiometabolic benefits. So thank you. And thanks for patient listening.
Thank you, sir, for this beautiful presentation. Moving on to the questions that have come from the audiences. The first question is, what does current research suggest about the likelihood and extent of weight regain after discontinuing GLP-1 receptor agonists?
So as I mentioned that these drugs, if you discontinue, there will be weight gain. There is no doubt about that. So whatever the weight loss is there, almost 2/3 of the weight will be regained in these individuals. So that will always be there. And remember, if your patient is losing 10%, 10 kgs of weight, then he'll regain around 5 to 6 kg once you stop GLP-1RAs. And next question.
Sir, are there specific patient profiles or comorbid conditions where weight regain post GLP-1RA discontinuation is more likely?
Yeah. So yes, people have studied that also, and weight regain is more likely in those patients who do not follow the lifestyle interventions after stopping the GLP-1RAs. So that's very important. Or somebody who is having comorbid diseases which impair the lifestyle modification, or patients who are on maybe steroids or other drugs which can lead to weight regain, they are more prone for weight regain.
Right, sir. The next question is, how do you approach long-term weight management in patients who discontinue GLP-1RAs due to side effects, cost, or some other reason?
Absolutely. This is a very, very important question, that how do we maintain that weight loss? It's really difficult, and it's very true. Maintenance of weight loss is a trouble. But before saying maintenance of weight loss, having a weight loss is also important. So you can see many patients who are coming to your clinic. They say, doctor, we have tried so many things, but we don't lose weight. So at least these drugs cause weight loss. These drugs have metabolic benefits with weight loss. So if they can continue this drug for a quite long time, it's good. But suppose they don't want and they can't continue, then there would be weight regain. But at the end of the day, still 1/3 of the weight loss still persists, and that will be good thing. But stress upon lifestyle modification in these individuals.
Raisa, so these were the queries for today. So thank you so much for taking out your time and making effort for such a beautiful presentation and clarifying all the doubts that have come from our audiences. So, sir, before that, I would like to thank all the audiences for joining in. Thank you so
Okay.
much, sir. With that, we'd like to conclude the session for today.
Bye bye. Take care.